My name is Noam Suissa, and today I will be presenting my research titled Ultrasound Nerve Block Guidance Using Deep Learning. Ultrasound-guided peripheral nerve blocks are used to administer anesthesia to certain nerve regions of the body to reduce the feeling of pain before or after surgical procedures. These procedures make use of ultrasound feeds to guide a needle to a nerve of interest in order to inject anesthetic around it, effectively blocking sensation in that area of the body. This is great because it offers continuous visualization of various anatomical structures. Needle visualization and its path is also offered, as well as the visualization of local anesthetic delivery and its distribution. Peripheral nerve blocks in general avoid the need to prescribe addictive oral medication and induce general anesthesia. However, some limitations exist with these procedures that many studies point out. For example, they require extensive knowledge of sonoanatomy, leading to experience-related barriers. Limited experience can cause unwanted nerve, artery, or vein damage, local anesthetic toxicity, and in some rare cases, organ damage. And this could be further visualized in an image of the axillary brachial plexus. In this image, the radial, ulnar, median, and musculocutaneous nerves are all present and difficult to locate. It is the anesthetist's job to locate them at all times throughout the entire procedure and avoid the needle touching unwanted structures. And despite the lengthy and intensive training that anesthetists go through to perform these procedures, studies show that there are often disagreements on sonoanatomy. And this brings me to my research. A deep learning software solution is proposed to address these limitations by providing anesthetists with a tool capable of accurately locating nerve regions in real time via ultrasound. The study so far focuses on locating the transversus abdominis plane and femoral nerve regions. Now, before I dive into the specifics of my research, I would like to give you a brief introduction on the inner workings of convolutional neural networks. The way CNNs process images is inspired by the way the neural connections in the human visual cortex process and extract features from what we see every day. So don't be too afraid of this image if it seems very complicated. We'll break it down together. What this image shows is that a typical CNN consists of three parts. First, an input image is fed to the network so that it can classify what object it is. Then, a series of convolution and pooling layers, which I will explain in the next slides, successively break the image down into low-level all the way to high-level feature sets. So in this case, the first layers might extract low-level features, such as the rounded edges of the car's roof or the difference in contrast between the headlights and the surrounding paint. And as we go down to deeper layers, the network will extract higher level features such as the side mirrors, headlights, wheels, the front grille, etc. And finally, the feature maps can then be passed to a classifier so that it can make a prediction on what the object is or consists of. So now let's take a look at the convolution operation. This operation makes use of a filter that can be seen here in the form of a matrix. Each filter's job is to extract one particular feature from an image. Yet the question begs, how is this accomplished? Each filter contains weights that start off as random, but as the model is trained, the weights adapt and get better at extracting different features. So take this example, for instance. The filter here is called an outline filter. You can immediately notice that all the weights are negative, except for the middle one. If we were to window the filter over the entire input image and take the weighted sum of the weights and the pixel values, then we can effectively extract the feature that this filter is trying to extract, namely the outlines. And here we can see the resulting image. We immediately notice that all the regions that appear to have no significant change in contrast or suppressed, in other words, are black, while the regions with dips in contrast are enhanced and are white. This particular outline filter can be one of many in a convolutional neural network. A typical CNN contains hundreds of filters, and each of them are capable of learning different high and low level features of an image. Now, moving on to the pooling operation. In order to reduce the computational load required to train the model, we need to perform a max pooling. This operation involves taking the largest pixel value in a given window to produce the output pixel. The window then slides over and repeats the process until the whole image has been covered. The resulting image is not only smaller in size, but contains the brighter and dominant features while excluding the darker ones. So to apply this to our previously convoluted image, we go from this image to this one. And we can see here, all dark regions have gone completely black to make the brighter regions stand out even more. And moreover, the dimensions of the image have also been reduced to alleviate the computational load while training the model. Now moving on to the objective and hypothesis, the objective is to accurately segment the tap and femoral nerve regions in an ultrasound feed in real time. Furthermore, the hypothesis is that a trained deep learning algorithm can make predictions on the nerve location with a minimum accuracy of 70%. For our methods, we are using the UNet architecture, which has gained a lot of traction in the biomedical field for deep learning tasks since 2015 when it was first proposed. The reason being that it is very good at training a model on a limited number of images, which is usually the case in the biomedical field. The image of the UNet shown here can be quite confusing to look at, but we can notice two things. First, the architecture gets its name from its particular U-shape. And second, the UNet consists of a series of convolution layers depicted as blue arrows and pooling layers seen here in the red and green arrows. Lastly, the output of a UNet is a segmentation map, which in other words is just an image containing the outline of the nerve's location for our specific case. In terms of dataset sizes, the TAP training set contains 554 images sourced from a YouTube video. The test set contains 10 images labeled by 3 different anesthetists, with one of them labeling each image twice, several weeks apart. Effectively, this makes for a test set of 40 images. For the femoral nerve dataset, 562 images were found online and labeled. 500 were used for training, while 62 were used for testing. In our methods, we also use the common technique of augmenting our dataset. Augmenting a dataset is a technique used to artificially increase the size of your training set by introducing changes in the original images, effectively making them new, never before seen images. In this project, 5 augmentation techniques were used, and in addition to those 5, models were trained on no augmentations and all augmentations. And the 10 parameters that control the behavior of the 5 augmentation methods were randomly chosen from predefined and validated ranges every time an augmentation was made. In the following slides, we will demonstrate the augmentations. So just to note that the left column shows the original image and its mask, while the right one shows the augmented versions. So in this augmentation, we flip the image and its mask horizontally. Moving on, we have a rotation augmentation. Then we have the gamma intensity augmentation, where we brighten or darken the image, and this mimics the gain function on ultrasound devices. Then we have the elastic deformation, which adds a bit of warping to the image. And finally, we have the Gaussian shadow. And the Gaussian shadow here can be seen in the top middle portion of the right image. And it's basically introducing a shadow with a Gaussian spread. And this can mimic air pockets that are sometimes found in the body. So after having trained a model, all images in the test set were passed to make predictions on where the nerve is located. Using the DICE score, a percentage on how well the prediction matches the labeled nerve was reported. The DICE score equation is calculated by taking 2 times the number of true positive pixels over 2 times the number of true positive pixels plus the false positives and the false negatives. And lastly, the performance metrics that was chosen was the mean DICE score of the entire test set. Across all trainings for the TAP data set, the model that was trained on the set containing rotation received the highest mean DICE score of 79.15%. As for the femoral nerve results, the model that was trained on all augmentations received the highest mean DICE score of 82.35%. So while the quantitative results are great for showing the training performance of the model, the qualitative results should be considered as important. In the next slide, a short video demonstration of the predictions of my TAP nerve are shown in real time. So here we can see in green the predictions of where my TAP nerve is located, and to the naked eye, the predictions seem to be very successful. So in conclusion, our results have shown that it is possible to train future models to recognize other major nerve regions in the body and have demonstrated advancements in accurately detecting the TAP and femoral nerve regions. Moreover, the UNet architecture has proven itself to be a great candidate for the segmentation tasks in biomedical applications, specifically for ultrasound nerve block guidance. In terms of future work, tasks might include adding new major nerve regions to train a model on, predicting the location of other anatomical structures in ultrasound feeds, and designing a novel graphical user interface to present all of our features in one place. I want to give a special thanks to my supervisor, Dr. Thomas Hemmerling, Dr. Chantal Cyr, other collaborators, and the entire collaborative team at ITAG Laboratories. Thank you very much for taking the time to listen to me and my presentation. I will now open the floor to questions.
Thank you very much. Yeah, that was quite impressive. Very nice presentation. So it's open for questions. If anybody has any questions, you could open up your mic.
Hi, I would like to ask a question if possible. Using the UNet, it's obviously cutting edge, and I noticed in our diagram the contracting part, which is kind of like the first side of the method. But can you please explain me, because this is a supervised convolutional network, neural network type of learning. What is the difference if you would have used an unsupervised one? Why did you use the supervised one?
Well, yeah, that's a great question. We go with the supervised because we want to have the experts label the images, and there isn't a lot of work or publications out there that have done unsupervised work or unsupervised models or trainings for these specific tasks. So we found already some studies that have highlighted nerves or other anatomical structures in ultrasound feeds, and they've all gone. It's surprising to see that they've all gone with the UNet or variations of the UNet. So that's why we've chosen the UNet and the supervised method.
Okay, so access to the specialist was kind of the factor.
Absolutely.
Makes sense. Thank you very much.
No problem.
Awesome. Very good.
Thank you very much.
Any other questions? Could always ask afterwards. I'm sure it's always open for future questions. I think because of time, interest in time, we'll move on to our next presenter. So the next presenter is Sean Jeffries, a non-thesis master candidate in Dr. Hemmerling's lab. And his talk will be a novel bariatric-specific laparoscopic stimulator.
Okay, so as hopefully was already previously mentioned, I'm here today to talk about our laboratory's development of a novel bariatric-specific laparoscopic simulator. So starting with the disease state analysis, obesity is widely recognized as a growing health epidemic. We believe this means it is time to strive towards potential solutions to help mitigate the challenges this patient population deals with, while also recognizing the realities of the situation. In 2022 alone, more than 2 billion adults were classified as overweight or obese. This number is greater than 25% in most first world countries. Approximately 1 in 4 Canadian adults are currently obese, and this number is predicted to affect more than 1 in 3 Canadians by 2032. In terms of the anatomy and physiology, obesity is defined as an excess of body fat or a BMI in excess of 30. The visceral or internal fat is directly related to the severity of the obesity. Comorbidities often affect cardiovascular and respiratory systems. Most notably for this talk, it is also associated with worse postoperative outcomes. In terms of laparoscopy in bariatric patients, laparoscopy is a minimally invasive surgical technique. It is used for surgery involving abdominal or genital organs. And the clinical outcomes in laparoscopy are that it yields 70 to 80% surgical site infection reduction in obese patients. You have reduced postoperative pain, faster recoveries, and decreased postoperative morbidity. In terms of pathophysiology relevant to surgery success, obese patients have decreased intraoperative visibility, shifted anatomical landmarks, and extra thick subcutaneous tissue. This makes it often difficult when handling laparoscopic instruments, as these patients are often quite different than what general surgeons or pediatric surgeons are typically trained on when they first begin their training. So why build a simulator? Well, many factors favor the need for simulation in training and assessing surgical residents' performance. There's currently a complete lack of non-patient models for training surgical residents, specialized techniques required when dealing with abnormal patient populations. As you can see here, this is the current state of simulator solutions in bariatric surgery, which is essentially a fat suit put over top of a previously existing general surgery mannequin. So by building and validating one such simulator, we can help fill this gap in medical education. We've therefore set out to build a high-fidelity bariatric surgical trainer that mimics the biomechanical properties and feel of live tissue. So our objectives are twofold. One, the fabrication and validation of a benchtop simulator with which residents can safely learn the intricacies of bariatric procedures outside of the operating room. And two, the long-term improvement of bariatric surgery patient outcomes. We hypothesized that through the use of previously validated Likert scale questionnaires, following simulation testing, attending physicians and senior residents will rate our simulator as a valid surgical task trainer. We also hypothesized that during testing, expert surgeons will significantly outperform novices in all surgical performance metrics. So how did we actually create this thing? Well, in terms of the simulator's fabrication, the skin and subcutaneous tissue was created inside of a custom designed 3D printed mold by recording the dimensions of a real anonymized patient. This data was imported into Autodesk Mixer and simplified using the software before conversion to STL files, which are files typically used in 3D printing. The 3D printing of the mold was segmented into 12 separate pieces and printed via PLA filament, which is essentially just a very hard plastic. You can see the process of creating it right here, and this was the final end result, which was then printed into a front and back mold. So the front half of the mold was used for creating the skin and subcutaneous tissue, while the back half was utilized as a shell to house the simulator's base. Specialized high-fidelity silicone was designed to mimic the real tissue. This tissue has self-healing properties for multi-use functionality. So when you make cuts, you can actually not worry about them. They should self-heal, and it is temperature dependent, and you can reuse the simulator pretty much as many times as you want. We've used ours about 40 times, and it's still going strong. So here's the manufacturing steps, the finalized shell that we constructed for the mold, the pouring and drying of silicone in the mold, and the silicone-based foam layer over top of the skin, which was used for the subcutaneous tissue simulation. In terms of electronics, we had 4 actuators powering 2 vertical arches, 2 actuators powering 1 horizontal arch, a 3D printed arches and cross brace, and a 12-volt external battery to drive the actuators. So we used basic copper wiring to create a circuit connecting the 6 actuators in series to rocker switches, which were then paired to a battery, which allowed it to drive the actuators upward. So here you can see the cross brace and arches, and they're all connected, wired together to the switches, which once turned on, would allow the battery to power the arches upwards with about 150 newtons of force to a height of 10 centimeters. This is actually modular, it can be manipulated, but 6 to 10 centimeters is typically what is done. And this allows for a simulation of the pneumoperitoneum. Now, pneumoperitoneum, for those who don't know, is when you insufflate the abdominal cavity using a gas, such as CO2, and it allows the operative pocket to have more room and more space for instruments so the surgeons can move more freely. In terms of the preparation of primary organs, I have an example of the stomach, which was prepared in similar fashion to the mold, where we found the average size of a bariatric patient's stomach. We then created a mold of said stomach using the same 3D printing techniques. We poured silicone in the mold, and we synthesized the 2 halves of the mold through surgical stapling, stuffing with insulation, and a final setting of silicone to seal it all together. Notably, there's a hole up here that allows air to travel through, so the stomach can be compressed, and if punctured, nothing will happen. And it really does feel like a live stomach for anyone who has actually felt one before. In terms of the gastric band, so we're going to be using a gastric band removal procedure to first utilize and test the simulator. So we prepared a gastric band using a similar technique and 3D printing. We have a rubber band we created here, and it will be wrapped around the stomach. It must be cut in the surgery and removed carefully through properly placed trocars. In terms of the operative zone of our simulator, it was also constructed using a 3D printed box. The primary organs were capable of manipulation, and the secondary organs you can see here are textile fabric, and they're actually set in place via Velcro. We chose these organs because they are the main organs relevant to surgical success in the gastric band removal procedures. So we have a liver, a stomach, a spleen, a small intestine, a large intestine, and just the fascia, which is insulation. We actually do have plans to increase the fidelity of all the secondary organs, which I've delineated as 2s here, with the primaries being 1s, but we just haven't yet accomplished that. In terms of the full fabrication of the simulator, here you can see an insulated abdominal cavity with the simulator top connected to its base. And here you have the basic surgical setup we have for the gastric band removal procedure. So in terms of validating the simulator, how do we do that? Well, the most prevalent current way to validate a surgical simulator is through face, content, and construct validity testing. For those who don't know, I'm going to run through those quickly. So face validity is looking at how suitable content of a test seems to be on the surface. Content validity is assessing if a test is truly representative of all aspects of the content. And construct validity is evaluating whether a measurement tool really represents the thing we're interested in measuring. A basic example I've come up here to help everyone understand this a little bit better is for face validity. You're looking at, does the professor agree if a final exam is sufficient at testing knowledge? So if an expert agrees on it, then on the face, it looks good. Now for the content validity, does the exam actually cover everything taught? So you're looking at the content of the test and whether it's actually accurate in testing what we're trying to test. And for construct validity, does passing the exam make you a better physician? So this is a more overarching look at validity and seeing if the measurement tool really represents what we're interested in measuring. So for a data collection and analysis of our simulator's validation, we're going to have our face and content validation being obtained via questionnaires. These questionnaires will be administered both preoperatively and postoperatively. And for construct validation, we're going to be using OSAT scoring sheet, which I'll go over in detail in a few seconds. So participants' data and responses will be anonymized to eliminate conflicts of interest. We're looking at recruiting around 5 participants at each educational stage. So we've split these stages into medical students, senior residents, junior residents, bariatric fellows, and attending surgeons for a total sample size of about 25. All the recruitment will take place through McGill University Hospital Network. And in terms of analysis, student t-tests will be used to compare mean scores on questionnaires, and kappa scores will be calculated to measure agreement between evaluators. So here we have an example of our pre-study questionnaire. We're going to be looking at the qualitative data of the participants before they actually perform the operation. So we're going to be asking them pretty much what is their experience in these kind of procedures, if any, if they're right or left-handed, what educational level are they at, and what is their essentially their background. And then our post-study questionnaire is looking at more of how did they feel through the simulation? Did they find that it was similar to the OR? Was some of the aspects of the simulator moderately realistic in terms of feel of the tissue? And what level of surgical trainees do you think would be suitable for using this simulator? And how many hours of training on the simulator do you think would be required to actually obtain safety and efficiency in the gastric band removal procedure? So for our construct validation, we're using the OSAT score, like previously mentioned. So it is a commonly utilized sheet for scoring surgical trainee performance. It tracks the basic surgical skills tailored to a given procedure and the time until completion of the procedure. It is typically completed by supervising physicians, and it allows for the differentiation between novice and senior residents based on the final score obtained. So here's our modified OSAT score. So as I mentioned, you're looking at stuff like the tip of the instrument being continually visible on screen, which is important. Is the tissue used with the left instrument and right instrument? You have to have dexterity in these procedures. And do you have smooth movements? How is your depth perception? How is your efficiency, your tissue handling, your autonomy during the procedure? And how do you really move about in the operative pocket? And of course, we're also measuring the time until completion of the task. In terms of results, well, testing has actually just begun. It's currently ongoing. No data is going to be released until completion of the trials. However, a pilot study was run in January to gain technical feedback, where we took experienced surgeons and asked them to test out the simulator and provide areas for improvement and generic feedback. This was done via a technical questionnaire, very similar to the postoperative questionnaire I already showed you. So the technical feedback questionnaire was looking at how realistic is the tissue, how comparable to the OR or some of the organs and different aspects of the simulator, and pretty much what is your overall feel on whether or not this was a viable and useful tool for simulating gastric band removal procedures. In terms of the results of the technical findings, it was rated by 3 experienced bariatric surgeons. It was given great initial positive feedback, even though it was a prototype, and the overall mean score was 4.2 out of 5 on the Likert scale questionnaires. So it scored very well in FLS comparison to currently available surgical trainers. It was seen as a useful tool in improving the surgical skill sets, And there was unfortunately a clear need for higher fidelity gastric band to improve the ability to assess trainees' overall competence, but we've actually already mitigated that problem and solved it because previously it was just a little piece of string we were using for the gastric band. And like I showed you previously, we've already 3D printed and created a more high fidelity, realistic gastric band procedure. So in terms of the discussion of these results, well, preliminary results highlight the potential for the simulator's application as a tool to improve bariatric surgical education. Our final results will allow for a more in-depth look into whether this tool is a valid laparoscopic surgical task trainer, and further investigation will be needed to confirm our simulator's broad efficacy as a useful tool in improving bariatric education and future patient outcomes. Our future research aims to introduce other bariatric procedures, such as a sleeve gastrectomy or other bariatric procedures. And we hope to implement virtual reality and augmented reality into these procedures. And finally, we also look to utilize recycled PLA or PET filament for trimming costs. So we wouldn't have to be wasting resources constantly and actually be able to use recycled plastics. In terms of a demonstration, I have a little video of our prototype, which you should be able to see here. So here's the insufflation of the abdominal cavity. Here you can see the placement of trocar at a pre-existing cut we've made. And soon you'll see the camera being inserted. Unfortunately, our video isn't very high quality, but we're using an actual laparoscopy tower in the real procedure. And here you can see a visualization of the primary organs. So I'd like to give a special thanks to my supervisor, Dr. Thomas Hemmerling, and the co-investigator on our pilot study, Dr. Jason Harley, who's helped us create the questionnaires and formulate the entire study. I'd also like to thank all of the physicians we consulted with and who helped us build the simulator, as well as the entire collaborative team at ITAG Laboratories. Thanks for listening, and if you have any questions, I'd be more than happy to answer them now.
Thank you, Sean. Yes, so it's open up for questions. If anybody has any questions, please open up your mic.
So, Sean, that's a really wonderful presentation. So I wanted to ask you, so there are currently a number of commercially available bariatric simulation products for practicing skills. So how does yours differ? What gap is it trying to fill?
Well, the gap we find is that of the commercially available products, a lot of them typically rely on VR and don't give you the proper tactile feedback that's necessary for actually gaining the skills that are going to be useful when translating to the actual operating room. So at the point of our construction, there were no actually commercially available products that were capable of mimicking the tactile feedback of real tissue that residents need to have in order to bring those skills and transfer them to the OR.
Okay, thanks.
Anybody else?
Yes, I'm already. Hi, Sean. It's really interesting because you're using techniques from dentistry and from special effects in movies by using the silicone forms. And then I think the most interesting thing about this project for me is the fact that this is open research. We are all used with open publishing and open source, but this is open research. So basically you're putting the research up there for everybody to collaborate. Now, for the open research, you have three options to go. One is to release it in the public domain, and then it will happen, whatever it will happen. The second is you just go after an open source type of licensing, like Creative Commons, where if I am improving on something, I have to add it to your project. And the third one, which is the GNU type of licensing, which is kind of like, okay, I'm putting out there and you do whatever you want, you just have to put my name on it. Which one would you consider going? For me, I would consider going with the Creative Commons, because I will still have control on the bulk of research, but I will have to attract other researchers to work with my model. What are your thoughts on this one? But it's absolutely fabulous because open research in this time shows kind of the humanity and the care for well-being and the suffering of others without that have no means, especially in a lot of countries. Thank you very much.
Yeah, for sure. That's a fantastic question. At this stage, again, we're really working on our proof of concept and just trying to finish the simulator, really get it past the prototype stage, get into a more V2 model, and make sure that it's doing exactly what we want it to do. Everything you've suggested are things we've looked at. As at this stage, like I've mentioned, we're more so looking at publishing in some technical papers, hopefully getting some engineering feedback. And like you said, we're actually using Hollywood effects in a lot of our simulations. So we want to collaborate more with people on that end and try and make it as high fidelity as possible. And that's something that we have looked into, but it's more of a later down the road thing than something we're focusing on right now, even though we are collaborating with other labs and we do plan on publishing this research in the very near future.
Thank you very much. I was meaning you're doing it now because the Silicon Institute in Prosthetics and Special Effects VR, it's down the line. I can see that. Thank you.
Thank you.
So one silly question, actually. Is there any need to put like fluids or anything inside to simulate the humidity of internal organs?
Yeah, so again, this is, we're at the prototype stage. So we have a lot of really unique, cool ideas for doing this. We are thinking of adding an endoscope as well to really add some extra procedures. We're looking at working on adding some urinary organs so we can have it as a urology simulator as well. And definitely looking at putting fluids in would be perfect for especially the OSAT sheet, because it's pretty obvious if you puncture something you're not supposed to. And yes, we want to be able to train that.
Perfect. Well, thank you very much.
So thank you very much. The two speakers, really wonderful. So it is my pleasure to introduce Dr. Hemmerling, who received his MD from the Faculty of Medicine at the University of Saarland in Germany in 1990. He's also the director of the ITAG, which is Innovative Technologies in Anesthesia Group Lab. He's also an associate professor at the Department of Anesthesia and Division of Experimental Surgery here at McGill. He's also affiliated to the Institute of Biomedical Engineering at the University of Montreal. He's an editor for Anesthesia and Analgesia Junior, and a board member of the STA, Society for Technology in Anesthesia, for which he is the head of the research committee chair. So it's my pleasure to welcome you, Dr. Hemmerling. It's all yours.
Thank you very much. I'm probably a bit old-fashioned because my presentation is actually live. Had I known that I could pre-record it, I would have done it before, but please spare with me. And that's why Sean actually will move the slides forward for me for organizational purposes. What I want to talk to you about is a more personal view on simulation in healthcare and specifically surgery, based on my own experience, based on what we have published before. And then in the second part of my talk, I want to go back to a more broader view on artificial intelligence, specifically in anesthesia, to give you a little bit the scope of what the two students have talked about and what we have looked at and done the research, I would say in the last 10 years in the laboratory. Sean, if you move the slide forward, I will give you a little history of surgical simulation because it's a little bit separate. This is based on an article which we have published in 2017. Roy Kazan is the first author. He did a PhD in our lab and is now a final year resident in plastic surgery. And we looked at the history of simulation in surgery. And we noticed that it actually goes back to over 2,000 years ago, where the first rather innovative procedures were already simulated before using very simple tools. when you go a little bit more into details, you will find that then roughly about 500 to 1,000 before Christ, you can already find surgical simulation using either leaf or clay models in India to train doctors, physicians, although probably they weren't called like that in those years, to do nasal reconstructions with a forehead flap. Why the noses were so important? Because they were usually cut off in combat. So we had a lot of people, and you can actually see it even in some of the paintings and some of the drawings in those years, where obviously the noses were damaged and needed to do, and the reconstruction needed to be done. Other examples then later on included more wooden models, benchtop models, and then obviously later on, especially in the Middle Ages, work on human cadavers and obviously live animals. Now, in a way, live animals is a sort of a simulation, but I wouldn't necessarily characterize it as a specific simulation, in my opinion. Because in my opinion, medical simulation needs to have something which is either dead or fabricated. If you train it on live animals, it's basically a similar type of surgery. The next great advancement in simulation were then in the 1980s. And in all fairness, it was actually in the anesthesia departments all over the world where the first simulators were designed and manufactured. The so-called mannequins became then a very integral part of anesthesia training. Some surgeons say it's because our procedures are more simple than the ones the surgeons use. And in fact, what anesthesiologists do comprises usually of anything between 5 and 10 more invasive procedures, and they can actually easily be simulated using different kind of mannequins. And then the innovation progressed in the 90s with the introduction of virtual reality, and then later on augmented reality, although I feel that in the last couple of years it got stuck a little bit, but the next step of that mannequin training was virtual reality, and it's definitely something which is worked on, and we will probably introduce it as well. The next slide shows you a rough timeline of the simulation. And I only want to point out a couple of things. A lot of simulation training goes back to flight simulators. Now, these flight simulators were actually already developed before the Second World War. And then obviously you find there is a gap in terms of the simulator development. And then in the 60s, we go with more advanced simulators in terms of like vital sign simulators, and the first surgical simulators was actually then more in the early 90s, developed in the early 90s, especially the laparoscopic gallbladder simulator, which was developed in 92. One of the simulators we actually have in the lab is the so-called Lab Mentor, which is a virtual reality-based laparoscopic simulator. And as Sean pointed out, if you actually use that thing, what you notice is that it is actually very, very basic, and it doesn't give you any haptic feedback. And that's one of the major problems. It's visually quite nice to look at, but it gives you zero feedback. So for a surgeon, that's actually very poor. There are other simulators then where early simulators where people were trained for laparoscopic surgery, where there was only a blind box, and to get some haptic feedback, you basically manipulated little annulus, little rings. So the haptic feedback is, in all fairness, a major problem with these surgical simulators. As you can see, we've put in the timeline one simulator, which we're going to show you later on. It's the mammoplasty part task trainer, and I'm going to show you the video of that at the end of the first part of my presentation. So you see that there is an interrupted timeline. So we're starting with flight simulators, then obviously the World War kicks in. Then we have early surgical simulators, and from the early surgical simulators in the 1990s till 2010, there's not that much development other than some introduction of virtual reality, but there's a definite lack of haptic feedback. I want to, the next slide shows my personal experience with simulator. This is actually from my personal training in anesthesia. This is in size-wise the number 3 surgical or anesthesia training center in Germany. And this is actually close to, some people might know the city of Nuremberg. This is close to it. The university is based in Erlangen. And this is actually the first German simulation center. And that's the university department where I was trained. And I remember in the late 80s, we were all, when we were junior residents, we were always running through the simulation center in the first part of our training, and we went back to it a little bit later. So it was already part of the standard training in anesthesia in those years, and it was more and more developed afterwards. Now, for those of you who do not have an idea how actually a simulation training center is built, the next slide shows you a map and some kind of an idea how these things look like. Now, what you see is that you will always have some rooms where the simulator is placed, low or high fidelity simulator. And then you have obviously office space, and you have training spaces, now very often integrating virtual reality. What is most annoying, actually, if you undergo these trainings in the simulation center, is that basically somebody looks at you through a glass wall. It's almost as if you parade in front of the police and they want to identify you. It's quite uncomfortable initially, so you have to get used to it. But the whole purpose, obviously, of these centers is that you have a team of people who actually, especially when it comes to team training, look exactly at how the team functions together, how certain decisions are made, and what pitfalls are, and where there are questions. So a lot of the feedback is then given later on in a debriefing room by these people who look at it, who record the actual interventions, and that's the key part of this simulation. So especially when it comes to training of events which are not actually that common. Now, resuscitation, I don't do that often. I think I've resuscitated people in the operating room, I don't know, throughout the last 10 years, maybe 5 or 6. So it's not a very common event. So the simulation centers, they specialize on training people on these rare events, because it's something which you have to be ready to do when it occurs, and you don't actually get enough training in your usual clinical practice. So that's basically standard setup of any simulation center, including ours at McGill. And then in the next slide, I'll show you how then these simulators and the simulations are evaluated. Hopefully you can read this nicely, but I'm going to go through these 12 points for simulators. So first of all, you have to see what is the spectrum, what is the purpose of your simulation? What do you actually do? Are you doing, like here, for example, a training? Are you doing a performance assessment? So it's a broad spectrum of things you can do. Now, you obviously have to look at who's participating in the simulation. So it's very often the team training. Then you have to look at what is the experience level of the participants. Are we talking about residents, fellows, experienced surgeons, for example? As Sean has pointed out, in most of the studies you evaluate your new simulator by using different groups of trained participants. You look at what are the healthcare domains of these people and the participants, and where is it applied? What are the disciplines involved? Are there nurses? Are there physicians? Are there managers? What is the spectrum of knowledge and skill and behavior you are addressing? What are you actually looking at? Are you looking at decision making? Are you actually at specific surgical skills like we want to do? That's an important aspect to evaluate simulators. What is the age of the participants or the age of the patients? And what technologies are you using? Are you using a computer-based simulator? Are you using a hands-on trainer? Are you using a part-task trainer, which is a physical trainer, as you will see it later on in the video I'm going to show you? What is the spectrum of the site of the simulator? Before, simulators were usually in dedicated sites. Now we're moving a little bit away from it to more mobile simulators to be just more flexible and to basically accommodate more people. What is the extent of the direct participation? Are we having a hands-on training? Is it a remote simulation, which I regularly do? For example, in anesthesia, I have these login modules from the American Society, which I usually train on once a year. What is the spectrum of feedback you are getting? It's very often a real-time debriefing right afterwards, a real-time mentoring. And what is the embedding of the simulation in the specific organization? Is, for example, the application of what you do in the simulation, is that rarely implemented or embedded in your hospital, for example, or not? So these are the 12 key aspects which every simulator and every simulation needs to be looked at. And the next slide shows you components. Simulator components are very important in how you actually make them. And as you've seen here, this is one of our simulators, which we have created a couple of years ago, I think in 2014, 15 something. This is a simulator which surgeons can use to train themselves on breast reconstruction. So when you basically do a mastectomy, so you take part of the breast away and you want to reconstruct that breast, you want to have a simulator which is as close to a real breast as you can. And I'm not going to go into the different components, but it's important that every structure which is of any importance to the surgeon can be simulated by the simulator as well. And there's a lot of silicon modeling going on. There's not much which you can actually buy off the shelf. Very often there are molds which you have to do. I remember in those years with that simulator, for example, we did not use any 3D printing. Now we moved on with new technologies, and the huge 3D printer we have in the lab, we can actually facilitate the process, but there's a lot of hands-on training. So the students who actually work on that, they have to have actually a certain engineering component. They need to be able to build something in order to get a real simulator go. And when you then get a simulator, you can actually get a simulator which is pretty close to what you would see in an operating room. And the next slide and the next video will show you how we perform surgery in the simulator. So you see that basically the surgeon first marks the surgical site. You see that on the right side, there's a normal breast. On the left, we have the mastectomy. We're dissecting the actual pectoralis muscle. And this is a fast-forwarded simulation, obviously. So we then put in a certain texture, a certain fabric, which can simulate a fascia to basically give the whole structure solidity. It's actually the same which would be used in a real patient as well. When obviously the dissection is very profound and very deep, you have to set it up with that kind of fascia in there. It gets sutured. You need to be able to suture on a simulator. You see that there's a drainage putting in. Now this is a real implant. The implant gets put into that pocket. As you can see here, again, exactly the same way a real surgeon would do it in a real patient. It gets sutured around the fascia. And then you have to be able to close the different aspects of it. Here, you basically put in a little needle so that later on you can pump up that the volume in that implant, and the skin gets closed exactly the same way as you would do in a real patient. And that's exactly the same which we would try to achieve in the bariatric simulator, which we're about to develop and test with Sean. Now, to conclude this little more like a personal view of the simulation in surgery, I definitely feel that there is a lack of hands-on haptic simulators in surgery. And that I think the main focus should be on realistic representation of key aspects of surgery. And as well, and that actually was the most difficult thing for us, reusability of material. Now, for example, if you cut your skin and you suture it together, but then later on, you basically have to remake the skin for every procedure you're doing, that obviously is a problem. You remember when Sean showed you the introduction of the trocar in the bariatric simulator. If you put that trocar in and the hole stays, well, then you have to change the skin all the time. So how you create the silicon mixture is a very, very important part, and the reusability is another key aspect of any hands-on haptic simulator. If you like, we can either I can either open up now for questions, or I can do the second part, which looks into artificial intelligence. Really is up to you. If you feel that you're fresher for questions now, then I can open up the floor for questions now. If not, I can do the second part of my presentation.
I think there's a little bit more time if you want to use the time. It's until 2:30, so
I have a
ahead.
question. Sorry, I have a question at this point. Hi, Thomas.
Hi, Jake.
Hi, great talk. I'd just like to ask you something about the use of, it's not quite what you're talking about, but it's not unrelated. The use of simulation in selection of people for surgery and other clinical specialties that require some degree of dexterity. You know, I'm aware that in dentistry, they used to carve things, right, from soap or chalk, or, and then they, presumably through perhaps sensitivity about disability, they remove that requirement, but it doesn't change the fact that these are very dexterous professions. So could you comment on what you think about?
One of we have 2 or 3 simulators which we developed specifically together with Dr. Gilardino from the plastic surgery department. And one is, breast augmentation simulator. This is the breast reconstruction. And actually one of the, because Mirko obviously is very heavily involved in, or was before, specifically in training of residents, one of the objectives was actually, could we use that to select the right people for the residency program? And so I truly believe that if you look at our selection process, it's such a subjective thing, and you have the interviews, and you can judge as much as you want, right? You can look at the GPAs, you can look at all sorts of things, but at the end of the day, and especially for us as anesthesiologists, we obviously watch the surgeons later on. There are some surgeons which are, which know all the theoretical language, but they will never going to get really, really skilled in what they do. And for anesthetists, it's exactly the same, right? So I think the idea of these haptic simulators is they should actually be introduced in the selection process of residents in certain specialties, probably to start with, because it's a much smaller process, right? I mean, you're not overwhelmed with 50 people you have to pre-select, right? There might be, 10 invited in an interview process for a certain given residency. And I think it should actually be part of it to see how can they manage to do that? How can they, what's the skill level? We've done an interesting study at a certain point ages ago where we looked, for example, at the correlation between how the residents performed with certain games where hands-on games, right, where the skill level is the hand skill level is important, the tactile level is important, and compared that with how they performed in the simulator, and actually found a positive correlation. So that's another objective which actually is underemployed. Get them in, have them do the little, any kind of thing which involves haptic feedback, or which involves manual skills, and see how they perform. So there's a lot of options there to use it.
Just a quick comment on that then. Do you think that clumsy people, let's call them that, clumsy people are untrainable?
No, in all fairness, I don't think I was very good as a medical student in terms of my hand skills, right? So I think it moved on, and then some people have a steep learning curve, and others don't. But the problem is we live in a world where the competition is so hard, and so let's say you have 10 applicants for a certain specialty, for example, and you have 5 who are really good in all what you have evaluated during the interview. Where do you go from here? What is a fair process then to move on? Well, I personally think that if you test these 5 and their manual skill levels, for example, in a very simple simulator, and you find that one is really outstanding, I'd rather put my money in that one. Although I would agree that probably 2 or 3 of the other ones, they can develop as well. but in a fair selection process, you would probably put your money on the one who already knows how to run.
Thanks very much.
I might want to move on with the next talk. The next talk is a little we're stepping back a little bit. We're not talking about machine learning as such, but we're talking about the base of it, artificial intelligence. And if I look at my own lab, like 15 years ago, so we started, or actually more, we started more into the area of artificial intelligence. And then with the development of machine learning over the last couple of years, we moved on to the machine learning, which I think is an advancement of sheer artificial intelligence. And I want to sort of like make the distinction a little bit. Now, when you look at artificial intelligence, I'm talking mostly of anesthesia. It's obviously study of algorithms that give machines the ability to reason and perform functions, simple functions as problem solving, object word recognition, inference of world states, decision making. Okay, so it allows algorithms to make certain decisions based on how you program them. Whereas then when you look at the machine learning, these programs and these algorithms can learn themselves. They improve themselves over time. So there's a little distinction between the two parts. When you look at the artificial intelligence, and obviously, as you all know, the FDA is very slow in improving these kind of artificial intelligence systems. The first system approved by the FDA was in 2018. It's a software system which allows the diagnosis of diabetic retinopathy through the analysis of images. I want to present something here very shortly, which is based on a recent article in 2020. It's a review article. In the next slide, you see what they looked at. So this is a review article, and they looked at artificial intelligence in anesthesia. And I just use it for you to have an idea. Is this a very popular thing? Are there thousands of articles out there, or is that still a new field? And as you can see, is when you search these kind of huge databases, you come up with over 2,000 articles initially. But when you then tailor it down to true artificial intelligence in anesthesia, we're only talking about 170 studies. This is in 2020. So this is a new field in anesthesia and I guess in most other fields as well. So we're talking about a certain number of studies, and we're talking about a very basic, how can I put it, basic artificial intelligence system, which most experts or a lot of research groups are using right now. And it's this kind of, which we had actually looked at before in a more elaborate machine learning version of it. It's a neural network. A lot of people are using neural networks. I remember when we started our artificial intelligence, we used expert-based system, we used fuzzy logic, all sorts of things, and then came more and more into these neural networks of kind of artificial intelligence. And all it does basically is it mimics a little bit how we as human beings would function. So you have an input. So if I want to look at, for example, to decide and determine whether the patient is awake or asleep, well, I have some input layers, right? I look at the EEG power of my patient. I look at how the waves look like. You can get either the raw data or you have a derived parameter. You look at things like the blood pressure. You look at things like heart rate, or further on, heart rate variability. You put that into your hidden layers, right? That would be like almost like your brain thing. And then you come into output layers. So there are all these connections which are done based on algorithms, which you put into the machine. And then in the output, basically, that allows you with a certain accuracy, with a certain probability to decide and determine whether a patient is awake or asleep. And I want to just go through a couple of areas in anesthesia where artificial intelligence is currently used or used for research purposes, because very few are actually used in a clinical standard version. One of the machines, some of you who work in the OR have seen, you will see in the next slide. This is what I use on all my patients. I monitor all my patients with basically a derived parameter from an EEG, which gives me an idea of the depth of anesthesia monitoring. I use the bispectral index. All it basically does is it takes in data, EEG data from a patient. It puts it into algorithms using something which is called fast Fourier transformation, where it basically analyzes amplitudes and frequencies of waves and gives you a certain number, because we're simple creatures, anesthesiologists, so we need a number to look at. If you're a little bit more sophisticated, you actually look at the original EEG as well, which you don't see on this photo here, but I actually sometimes put it on and look at the actual waves as such. But it's very simple. 0 would equal no electric activity of the brain. Does not mean that you're dead, but it means that there's no electric activity. If I give you a big enough dose of propofol, your value will probably go down into the single digits or lower, depends on the propofol dose I give you. So it doesn't mean that you're dead. It just means that you have an isoelectric activity. And then you have a patient who is awake, and then we're talking about values around 95, 96, 97. And the target, for example, for an anesthesia is anything between 40 and 60. So this is basically a monitoring tool which I use every day. Now, the next slide shows you how you can improve this tool. So basically what people have done is, and we then look at accuracy of these tools. So they basically looked at 4 possible states based on something like the BIS, or an entropy index, which is very similar to the bispectral index. So 4 possible states of patients either awake, has light anesthesia, deep anesthesia, or general anesthesia shots. So awake, light, and deep anesthesia. And this, for example, was done in patients who underwent anesthesia using volatile anesthetics, in this case sevoflurane. And what I try to point out is if you use an artificial intelligence, so you have different other aspects which you put in your brain, so to speak, in your artificial brain, you will actually have a much higher accuracy to distinguish awake, light from deep anesthesia. Look at the differences. If I only use that index, that machine which I had just shown you, I would be able to predict these states with 75, 77%. But when I use artificial intelligence, I can significantly improve this detection level. Similar algorithms were done for propofol patients, and again, using the BIS index, exactly the machine which I have shown you. And you see that you can marginally, not in a big level, but you can improve the detection of awake versus a sleep state. So by using not only the BIS index, but certain aspects and certain parts of the EEG raw data, together with clinical data, putting into that artificial intelligence, we are able to improve the detection and the determination of different states of anesthesia. And artificial intelligence, in the next slide, has actually been used for many different aspects of anesthesia. As some of you know, we have many years ago designed a sort of like an anesthesia robot called McSleepy, and it had 3 parts of the anesthesia delivery, all the 3 parts which we actually use: hypnosis, analgesia, and muscle relaxation, controlled using these algorithms and using artificial intelligence, and it actually worked very, very well. And a lot of this is based as well on how the artificial intelligence is changing over time. How is it able to calculate certain rather complex calculations and algorithms, which I would not be able to do. If I was able to do that in the same amount of time and as quickly as the machine, I would probably be as good as them, but I wouldn't be able to do that. And I'm very often obviously multitasking. A lot of the new machines for critical care ventilation and ICU ventilations actually use mechanical ventilation, use some kind of artificial intelligence as well to predict, for example, when the patient can be weaned from mechanical ventilation, meaning that when is the patient able to breathe spontaneously. So there's a lot of artificial intelligence which is currently under investigation, not too much in clinical routine use, but there are definitely fields where artificial intelligence plays a role. I give you another example in the next slide, one which is in this one here, the event prediction. It's very difficult for us to predict, for example, hypertension. Right? I mean, I obviously measure the blood pressure on a regular basis in the operating room, but to predict when the hypertension actually occurs, when mean arterial pressure is less than a certain level, is very difficult for me, because I look at one value, well, I could predict something and so forth. So again, using artificial intelligence, you can actually, given the arterial line waveform, already predict 15 minutes before this actually happens, what or when hypertension, significant hypertension occurs. So imagine that would actually allow you to act much faster than what you're doing now. Now you're waiting, does it happen? And then I react. Whereas this would actually give you an idea when hypertension happens, or in the next 15 minutes or 30 minutes or whatever, and then you could react much more. So there are a lot of these database studies now using originally artificial intelligence, now a lot of machine learning models. That's why you see a lot of studies now published where they use huge databases. They feed the data in there and then try to come up with some machine learning models to detect and predict morbidity, weaning from ventilation, things like readmission, sepsis is a major objective for artificial intelligence. One of the studies I've read of late, I think 1 or 2 years ago, is shown in the next slide. Now we're moving towards more like the machine learning. As I said, keep in mind, machine learning is part of artificial intelligence. The difference is that we're thinking that the machine is able to learn quicker than we could, and therefore similar to human beings, able to improve over time. And you can see that if you use these kind of machine learning, where you put in 6 vital sign parameters and you compare that with normal scores, like organ failure scores or systemic inflammatory response scores, in order to detect sepsis, you see that in one of these single center studies, they could show that you can reduce significantly the hospital length of stay and as well the in-hospital mortality. So we're talking about a huge impact which these machine learning models could have in the future. And that's why machine learning, and especially machine learning using huge data sets, is one of the major research fields in anesthesia in the States. As mentioned in the introduction, I'm one of the editors on the technology section of the major American journal, Anesthesia, and I'm overrun almost by these studies where huge data sets are put into these algorithms and these machine learning models, trying to come up with better prediction and better outcome than we can do in using human beings. The next slide just shows a couple of other applications. There is obviously the application of machine learning in ultrasound identification, mostly in anatomical structures. Where we are hitting up is the nerve structures. They're a little bit more complex. So that's why there are not that many studies out there, although people are working on it. Pain management is one application for machine learning, and very simple things, again, very popular in the States, not so much here in Canada. Simple OR logistics. Can I create a machine learning tool to tell me how to optimize the flow, for example, of surgeries throughout the day? So there's huge applications for this in anesthesia and OR management. So I'd like to conclude with that. So field of anesthesia has really a long history of using and engaging in artificial intelligence. I truly believe it can impact what we do in terms of critical care delivery, in terms of pain management, in terms of simple anesthesia. And the importance is, and I remember when we talked about, Noam presented his thing in terms of the feedback of the users. I think it is very important that when you develop these machine learning models, that you get on the road feedback from experts, so you can actually, so that the machine learning models, yes, they will improve over time themselves, but you have to get the feedback from experts as well in order to titrate them, to tailor make them, and quickly develop them to a tool which hopefully can then surpass the human performance. So that's a little bit our philosophy when we design and develop machine learning tools. We always get the expert feedback right away, and we train the model as well using that feedback. That seems to me a very important aspect. And that concludes a little bit sort of like the overview of what we're doing in context to what my two students have presented before. Thanks.
Thank you very much, Dr. Hemmerling, for that wonderful presentations. Any questions? Professor Jason Haley.
Wonderful presentation. Thanks so much. I really enjoyed both parts. I wondered if you had any thoughts on, especially looking forward, and as the editor of a technical section of a major journal, in particular, thoughts on combining haptic feedback and simulations with artificial intelligence. As I think this is a very exciting direction, but would be interested in what you think.
Well, I have to admit, I'm a little bit disappointed in where the simulator development goes a little bit, because I have to admit, when we almost like 10 years ago started with surgically related simulators, we were very heavy on the virtual reality, and was thinking this is the new step, but it actually didn't kick up so much. So I think we have to focus a little bit more on development on the virtual reality as such, and in terms of the machine learning or the artificial intelligence, I think it's a matter, again, how you move from, I think the basis should always be a haptic feedback simulator. And then in sort of like a hybrid version, you have to have that virtual reality. And that's where the machine learning or artificial intelligence as such can kick in and develop that further. Guess augmented reality, where you have this hybrid experience as well, probably can play a role. But I think the problem, the sheer problem we have is in terms of developing the virtual reality and the machine learning part, is that it's a very costly aspect. It's not something which you can easily do, especially the virtual reality itself, because you have to have a graphic designer, you have to have a design group actually working on that. And that's probably a little bit of the pitfall we had in the past. But I truly believe that, and that's why I specifically chose those two talks together, because I had other students in the lab that actually artificial intelligence and simulation, that for me is almost a perfect fit, because it's so it's so similar in development. And again, the point is like, where do you go with what you have is, and how you can simulate certain events which are very rare. So again, the point is you have to put those two together. I think it's feasible, but I think it's A, costly, and B, you have to put a lot of effort into creating something which then later on is something which, how can I put it, mimics reality very much. When we had the lap band trainer in the lab, and we lifted this thing up, which weighs a ton, and we had then somebody playing around. And in a way, I wouldn't say it's artificial intelligence, but it's a virtual reality thing. Again, the point is, virtual reality, artificial intelligence without any haptic feedback, where people can actually suture something, is basically a lost art. I don't think that's the way to go. And maybe we're not mainstream in that, because I know that a lot of people going virtual reality, but in terms of what surgeons, anesthesiologists use, they actually need both of it together. I can tell you as well, as an editor, for example, simulation papers and technologies, they would only be probably 1% to 2% of the paper sent to me. So again, there's a huge research field which needs to be developed in that area, and which is not the case as yet, because obviously we're always jumping on artificial intelligence. How can we improve the clinical experience or clinical needs? But first, we should actually improve the simulation and the education of our people. So that's a little bit the philosophy, but it's not an easy task. That's why we have not been able to grasp that area of virtual reality and artificial intelligence in simulation too much, because I think there needs to be a whole team of graphic design. Why we work with these, not necessarily Hollywood guys, but guys from the movie industry. I mean, if you, for example, get somebody from Ubisoft on board, I think this would kickstart it, but we do not have those resources. That's a little bit my take on this. So I don't think it's easy to do, but I think it's the way to go.
Thanks so much, and great talks.
Any other questions? So apart from electroencephalography signals, which you talked about, what other data does one need in order to estimate the depth of anesthesia?
I mean, it's mostly vital signs. So things like blood pressure goes in there, heart rate variability goes in there. There are certain things, more modern tools like skin conductance, for example, gives you an idea of depth of anesthesia as such. But those are, and obviously the muscle relaxation as such. The more established parameter, which should go into like an anesthesia robot, is hypnosis, which could be EEG or derived EEG values or parameters. Hemodynamic parameters, so blood pressure, heart rate, and then muscle relaxation would be sort of like what we call twitch monitors. So basically you stimulate the nerve and you look at the muscle reaction. If you have these three components in there, you have a pretty solid input into your neural network, and then you can have the artificial intelligence create a pretty good anesthesia robot, so to speak.
Okay, thank you very much. Anybody wants to ask a question? Mike?
Actually, the question you asked was similar to what I was going to ask. No, yeah, no, it's very impressive.
So can you be able to personalize the input, the estimating the depth of anesthesia? Can you able to get data that can personalize?
Yeah, there's actually what happens actually when we built our robot, we used a principle called Bayes principle. The Bayes principle is a principle, well, more in philosophy, but it's a principle which basically means that you learn, you learn on with experience, very simply said. So what happened, for example, when we induce anesthesia, so when we put the patient to sleep, we obviously give certain doses, right? So we give certain medications in a certain form and in a certain dose. And how a patient reacts to these doses and what happens then to the parameters and the variables gives us an idea how a patient can be characterized. So to put it simply, one patient reacts a little bit more to the drugs, another reacts less. So what we did is we categorized a patient after the induction and then use that information to tailor make and to make our robot better for each individual patient. So yes, it's a titrated, individualized process which uses the data which we get by inducing anesthesia. That's how it works. So it sounds maybe simpler than it is, but that's basically it. So you learn first about the patient by looking at how he reacts to or she reacts to anesthesia, and then obviously the machine adjusts itself throughout time. So if throughout time the machine notices that, well, there's an offset from what it had calculated before, then it adjusts itself. And in all fairness, good anesthetists should do the same thing. I look at how my patient reacts initially when I induce anesthesia, and then I see how it reacts over time. So it's very similar.
Okay.
And just a follow-up, and that would correct for any sex-related differences in terms of anesthesiology?
In all fairness, contrary to the common thing, there's not so many differences in terms of actual sex between like woman, man, or any other binaries. It's more related to medication patients take. Age obviously is an important factor, and interestingly enough, it's a genetic predisposition as well. which is both probably genetic and sort of like a cultural habit. I'll give you an example, very, very simple, which I always use. I used to work in Saudi Arabia before I came over here to Canada. And I can tell you, like, I would give, in comparison to what I give here, 1/10 of the dose, and the patients would be outgone. And there's a genetic component to that, but then obviously culture as well. Like, for example, anybody who's not used to alcohol, as you can imagine, the whole metabolism changes a little bit. So it's actually quite interesting to see how patients from different genetic background react differently. And that you have to take into account, and you do it by creating a feedback system. As long as you have an objective measurement, I don't actually care what genetic background you have, because I'm measuring the effect of what I get. So in that respect, it simplifies the way anesthesia is applied much more than looking at, oh, what is the genetic disposition and so forth.
Really nice, thank you.
So thank you very much. I wanted to ask you a related question, probably not as, so can you be able to predict sepsis with this kind of algorithms?
Yeah, that's why I used it as an example, because a lot of these algorithms are actually used in ICU. One of the reasons is because ICU creates a lot of data pools, right? So you have big data, which comes from ICU and critical care and so on and so forth. So sepsis is, for example, one of the major applications for the artificial intelligence. It has to do with the fact that a simple diagnosis on sepsis is actually not that simple. You have to look at very different aspects. And so a lot of these artificial intelligence algorithms are actually super performant in ICU and in the diagnosis of sepsis, and a little bit less performing in other areas. So sepsis is one of the areas, in ICU actually as such is one of the areas where artificial intelligence is mostly used and has a huge future in my mind, because you are overloaded by complex data and by a huge amount of parameters. For example, in ICU, there are estimations that said that every patient basically creates about 100 parameters at any given time. So these are then fed into these neural networks, and that's why these systems are very performing there, probably as well because the clinical performance, so the performance of human beings, is very poor because we're overloaded by all these data. So the more complex the environment, the better performing these artificial intelligence systems. If it's very simple, like blood pressure, for example, as a single parameter, I can easily control. I'm not talking about anesthesia just as such, but as soon as I get 2, 3, 4, 5 or more parameters in it, it gets a bit complex for human beings. And then in addition, obviously the multitasking, which has become a huge factor in medicine, has obviously, overloaded us with information, and that's where these systems come into place.
That's great. Thank you very much. Any other questions? So if there are no more questions, I would like to thank Dr. Hemmerling and everybody for participating in this seminar, and the two students, really wonderful, excellent presentations. So thank you very much. Thank you. Bye, everyone. Thanks.